Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, you are most welcome for this session of tonight, which is going to be about history taking skill. History taking skill is one of the most fundamental skills in clinical medicine, and every doctor should master how to take history. And if history is taken efficiently, it leads to diagnosis of over 90% of cases just by history alone. And then the next step would be investigations. It would be targeted investigations. It would be problem targeted. It would be according to your provisional diagnosis. It's not going to be screening everywhere and where it hits, it's the right diagnosis. No, it's not like this. We are going from this lecture of tonight to know how to precisely take history and be to the point, and then investigate your patient according to your differential diagnosis. So it would be minimal sort of investigations, and this would save the resources. This would save the medical resources. So we have to be very much disciplined in history taking skill, and I'm going to show you the mechanical way of doing it. That's the steps through which you go and do history, and then how to interpret the findings. So by the end of this lecture, you would be able to take history from every patient in the most appropriate way in a timely manner. So we have to use what's known as problem-focused history in patients in the accident and emergency department, because we cannot go for detailed history that takes like 20 minutes in the emergency room. It would be just a problem-focused history. And I'm going to show you in the succeeding videos how to do it. So here we are. The first steps are very much fundamental and very important, because it would tell the whole story about your history, whether your patient is going to be comfortable with you or not. So the first step would be to greet your patient and make sure about his name and introduce yourself to the patient. So I'm Dr. Fulan, working for Dr. the consultant. You mentioned the name of your consultant. And if you are the consultant himself, of course, you are going to say your name. And then you are going to take full detailed history from your patient after making sure that this patient is the one. How to identify your patient? By 3 names and by the patient's number. And then a warm handshaking would put the patient at ease, and he would feel very much comfortable to tell you about his very private history. So what about putting the patient at ease? You make sure that your patient is comfortable, whether he's sitting on a chair like in the outpatient settings, or if he's comfortable on his bed in the accident and emergency department. And then you pull the curtains to ensure the privacy of the patient, and then you choose the appropriate settings for the different parts of history. For instance, if your patient is in the accident emergency department, you are not going to ask him about very private parts of his history. You're not going to ask him about his family history in details or his personal history in very much details. So, steps in taking history. We should always start by the personal history. And by personal history, we mean the patient's name, age, sex, residence, occupation, if he has got any traveling history, and his social status, whether he's married or single. This all makes like a good introduction to your patient so that you would know him. And also this helps in taking plans later on in the management and in the treatment and so forth. So put the patient at ease and ask him about the history of the presenting complaints. And if it's more than one, then you have to put it chronologically. And by the word chronologically, we mean in an ascending or descending pattern. either from the oldest to the nearest one or from the nearest to the oldest one. And then realize the importance of acute and chronic complaints. Like if the patient is having diarrhea, if it's for more than 2 weeks, then this is chronic diarrhea. And if it's less than 2 weeks, this is acute diarrhea. And each one has got its own differential diagnosis. So from the start, from every word the patient is saying, you are going to make an advantage of it and you are going to interpret it in the context of the history given so that you can reach the appropriate diagnosis. So encourage your patient to talk uninterruptedly. Once you start asking about the history of the presenting complaint, and then tell the patient, please tell me how it all started, or please tell me when was the last time you were well, and then what happened since then. This is all very important and encourages the patient to talk the whole story. And then later on, after he finishes, you can fill the gaps by asking different sorts of questions to reach the diagnosis. Use selective, precise words to clarify further. Use a language that's easy for the patient to know. Don't use medical words, medical terminologies. Use simple words that the patient knows. Follow the scheme all the time and take the personal history and then history of the presenting illness. In history of the presenting illness, you are going to take the details of the complaints. So you take them one by one, and then if they are pointing towards a system, then you are going to ask all the systemic inquiries of that particular system in the history of the presenting illness. Am I clear? For example, if the patient said, I have shortness of breath, so you are going to ask him all the questions about the respiratory system, all the systemic inquiries about the respiratory system and the cardiovascular system in the history of the presenting illness. And then regarding the systemic inquiries, you are going to touch on the other systems that the patient doesn't complain of. You got my point? This is very important point because by this you are going to reach the diagnosis very quickly. What about past medical history? You are going to enlist whether he has got diabetes, hypertension, hypothyroidism, tuberculosis, asthma. Those are the most important things and most common diseases encountered. Dyslipidemia also is important. What about the drug history? In drug history, you need to ask about 4 things. The prescribed medications, their doses, their frequency, and when it was started, and if he has got any adverse effects of it. The second thing would be the unprescribed medications. That's to say, the over-counter medications, the ones he just went to the pharmacy and brought them, because you will not find them in the system of your hospital. So what's number 3? Allergies. Is he allergic to penicillins, allergic to sulfa, allergic to any medications that he knows or not? And then for the drugs, the last one would be history of drug abuse, if appropriate. If you are suspecting that this patient might be having a problem with drug addiction, then you are going to ask. Otherwise, it's not a routine question. We have to be very sensitive to the feelings of our patients and to ask the questions only when appropriate. Family history. We're going to ask him about the details of his family and whether they have got a similar problem or not. And if they, for example, if a patient is diabetic, you are going to ask him about all other autoimmune diseases like thyroid diseases and so forth. So what about the social history? You are going to ask about history of smoking. It's very important to realize that the hubbly bubbly, or what's known as shisha in Arabic, is very important. It's just like smoking, and even worse than smoking, because in some literature it was claimed that just one set of hubbly bubbly is like equivalent to 15 cigarettes. So it's not something to ignore. It's very important, particularly if the patient is presenting with chest or cardiovascular system problems. Then if the patient is a female, you are going to ask about history of gynecological history, like history of menarche, regularity of her cycles. If she's married, then when was the last menstrual period? And in all females, this question is very important, particularly if you are considering doing x-rays. And then you check what's known as eyes. And by eyes, we mean ideas of the patient. What does he think about his problem? And concerns. What concerns him much? What brought him to the hospital this morning, or this afternoon, or this midnight? So, what about the expectations? What is he expecting from me to do for him? Those are all very important to ask about. Please avoid to interrupt your patient, because this would disrupt the sequence of events. The patient might forget important things that he was about to tell you. Let him finish and then fill the gaps by more questions. Giving close-ending questions. Avoid this completely. You have all the time to ask the patient open-ended questions, like how it all started, please. Can you tell me about the problem that brought you to the hospital today, and so forth. So don't ask questions that would have the answer of yes or no, because you would like your patient to tell you the whole story. So use open-ended questions. Don't forget the psychiatric history if it's appropriate. If your patient started telling you about the death of a beloved person, like a parent, one of the parents, or if a lady tells you about her husband's death, then you have to dig more, looking for any symptoms and signs of depression. Like you're going to ask about his sleep pattern and more questions according to the criteria of depression. So what about missing the eyes? It's not appropriate at all, because you need to know about the ideas, the concerns, and expectations of your patients. And by this, I would come up to the end of this history-taking skill of tonight. See you next slide. And up next would be more details about the history. Thank you so much.